aim today.
Yes.
Okay. So the aim today is to go to the background of brain tumors, and we'll see the two main categories of brain tumors that we deal with, how they present clinically, and what surgical techniques we have available and have been developed to surgically address these tumors. And finally, we'll go through a couple of clinical case scenarios to see how everything that we discuss is then translated into our real and everyday clinical practice. So when you go to tumors, we divide tumors into two broader groups. We have primary brain tumors, that are tumors that develop from the brain and within the brain itself. And these tumors are overall rare in the general population. They represent less than 2% of all tumors. However, they are relatively frequent in the young population, being the third leading cause of cancer-related death among the teenage and young population, up to in the span between 15 and 54 years of age. The gliomas, that are tumors that originate from the glial cells, astrocyte and oligodendroglial cells, are the most common primary brain tumors. They are usually divided into two broad groups, low-grade and high-grade gliomas. The low-grade gliomas characteristically have this genetic signature. They have a mutation in the IDH gene, IDH1 or 2. They are more frequent in younger patients, with a peak in the third and fourth decade. And they usually present with seizures. They are non-enhancing on scan, and they appear as hyperintense in T2 and FLAIR sequences, like the scan that you see on the top right of the screen. They are low grade, where low grade stands for low grade of malignancy. These are not benign tumor. The natural history is one of growth within the ears and eventually malignant transformation. So they progress from being low grade to high grade tumors. The high grade gliomas are distinct from low grade. They usually are IDH wild type, so they don't have the mutation. They're more frequent in the elderly, and usually they present with signs or symptoms of raised intracranial pressure, so pressure mounting inside the head, or neurological deficits like loss of speech or weakness. They appear as enhancing on MRI because they are quite malignant, and they can disrupt the blood-brain barrier. So when you inject the dye, they are localized. And obviously, they are associated with a poor prognosis. For glioblastoma, currently, the survival of the majority of patients is between 1 and 2 years from the time of diagnosis. The secondary brain tumors, and so this was the primary brain tumor groups, the gliomas being the most common, and secondary brain tumors are the metastases. So these are tumors that start somewhere else in the body, and then they eventually spread to the brain. These are the most common tumors that we see in the adult population. And the incidence changes whether you look at cancer registry or post-mortem studies, being higher usually at the time of autopsy. So post-mortem, you can see a higher incidence of these secondary tumors that are not even diagnosed. And they constitute a large part of our work as neuro-oncology surgeons, being 1 in 3 cases referred to us being one of these metastases, so secondary tumor. And we did a study at King's, we coordinated rather a multi-center observational study that enrolled many units from the United Kingdom, and we collected data about brain metastases. So you can see that the median age of patients diagnosed with a secondary metastasis to the brain is about 63 years old. So we are in a relatively elderly population, and there is a slight predominance of a female patient. Usually 50% of the metastases are single, and in the rest of the patients you have multiple metastases, whether 2 or more. The most common tumors that can metastasize to the brain are the usual tumors that you are familiar with: lung cancer, breast cancer, melanoma is the third. And then look at the table. The fourth is an unknown primary. So it is relatively frequent to have patients that present at the onset of their oncology disease with a brain metastasis. So how these tumors present in the clinical practice? So in a patient who presents with the following symptoms, the presence of a brain tumor should be suspected, particularly if they have a background history of cancer somewhere else in the body. And these are headache with a characteristic of intracranial pressure, and we'll go in detail about the symptoms of raised intracranial pressure. Onset of seizure, so a new onset of seizure in the adult life should always be investigated, and the brain tumor should be ruled out, or the onset of a new neurological deficit. And these are the presenting symptoms, again, from the study that we did, in this case on the brain metastasis. As you can see, majority of patients presented with a headache, and then followed by seizures and neurological deficit. There is a number of patients that are found to have tumors incidentally. So that means that they get scanned for other reasons, tinnitus, for example, being one of the common symptoms, or maybe having had sustained a head injury, and they get a scan, and on the scan, there is the finding of a brain tumor. So this is becoming also more and more frequent. A little bit more on the syndrome of raised intracranial pressure. This is very important that you learn to differentiate as medical students and then young doctors. So the symptoms is headache, but headache is a very common symptoms in the population, and not all patients that go and see their family doctors complaining of headache have brain tumor. In fact, is a tiny minority. Most common causes of headaches, you know them: migraine, tension headache, cluster headache. So these are all the headache problems that our neurology colleagues are familiar with. But when the headache is persistent, not relieved by analgesics, can wake patients at night, and characteristically is accompanied by other symptoms such as nausea and vomiting, or blurred vision and diplopia, these raise the suspicion of mounting pressure inside the brain, so raise intracranial pressure. And you know that the brain is a closed box, the skull is a closed box, so any tumor or any mass developing and increasing inside the brain will lead to a raise in the intracranial pressure. So it's very important that you familiarize with symptoms in order to be able to screen patients. The signs that you can look when you examine patients are the presence of papilledema, and this is the optic nerve swelling. You can see there the picture of a healthy retina on the left, and a papilledema, so raised intracranial pressure with the swollen optic disc on the right, and a false localizing sign, the presence of a 6 cranial nerve palsy. You can see the diagram on the bottom of the slide. And it's not clear why, but patients with raised intracranial pressure tend to develop a 6 cranial nerve palsy, which is a false localizing sign. It doesn't localize the lesion to the side where the palsy is, but it's thought to be related to the longer intracranial course of the 6 cranial nerve. Okay, so we have now gone a little bit about the background. We have seen how patients tend to present. So let's see how we can help our patients and what treatments we have available. And these are surgery, radiotherapy, and chemotherapy. These are the 3 established treatments that we have for these types of tumor. And there are some new and emerging therapies And what I'm going to focus in the rest of the talk is actually surgery, because that's what I do as a surgeon. Why surgery? What can we obtain with surgery? What is the goal? Well, there are many reasons why surgery is useful in the setting of and the treatment of brain tumors. The first thing is that you can improve symptoms, especially those arising from raised intracranial pressure. You can have a cytoreduction to help chemotherapy and radiotherapy, so that, for example, you debulk a tumor and then the radiation oncologist will have to treat a smaller volume with their radiotherapy, and this is clearly beneficial to patients. You will minimize a sampling error, meaning that removing a tumor, you will send a lot of tissue to the pathologist, and in these days of enhanced molecular and genetic diagnosis, this is also quite important. But the main reason why we do surgery is actually the last one. Surgery alone can improve the survival of patients. So it is a very important step in the multimodal and multidisciplinary approach that these patients require. And usually the first therapeutic step is, whenever possible, to try and remove as much as possible, as I said, of the tumor. And this has been proven time and time again for high-grade glioma. You can see this busy slide is just to show, this is a retrospective meta-analysis rather of the literature that has been done now almost 10 years ago. And the message, you can see it, I mean, the higher the extent of resection, the better the survival. And this is also true for low-grade glioma. Again, the higher the extent of resection, the better the survival. A study that has been done in Norway compared to university hospitals. There were the two centers where neurosurgery is available in Norway. And you can see that in Hospital B, the preferred approach in treating low-grade glioma was to perform a surgical resection. So, as we said, try to remove as much as possible of the tumor. While in Hospital A, the preferred approach was to do a biopsy, followed by observation or radio and chemotherapy. And you can see that the Kaplan-Meier curve justify the policy that was preferred in Hospital B. In other words, they elegantly demonstrated that whenever you can, you should resect this tumor because they end up with a better survival. In low doing early surgery or delaying that natural history that we described of a transformation from low grade to higher grade of tumors. What's the problem, however? The brain is a special organ, you know, I mean, that's why I decided to be a neurosurgeon, because it's the most fascinating organ in our body, in my opinion. And you can't just chop away large parts of the brain. Tumors tend to localize in eloquent areas of the brain, areas that are important for speech, for movement, and for other functions. So surgery of tumors, and particularly the intrinsic, the primary tumor, the gliomas, is surgery of the eloquent brain. And at King's, we looked at our experience in brain mapping, and okay, if we offer a general adult oncology service, how many of our patients will require brain mapping? And we've seen that 25% of the craniotomy and 40% of the glioma cases do eventually require some form of brain mapping, that is, investigations to find where the function is to avoid the damage to the brain. And so this is, again, a key message that I want to give you, that surgery for brain tumors is surgery of the eloquent brain. And so we need to come up with strategies that can help us to maximize the extent of resection while minimizing the risks associated with surgery. In other words, we need to be able to remove as much as possible of the tumor without causing significant and severe neurological deficit to our patients. At King's, but like in many other hospitals around the world, there are a few tools that we can use to accomplish this target. And one of the things is obtain a preoperative mapping. So if you have a patient with a brain tumor, you want to be able, if possible, to do a mapping of function preoperatively so that you can localize the areas that are important for patients so that you know in advance which areas you have to spare. And one way is to use transcranial magnetic stimulation, which is a non-invasive way. With a coil that generates an electric field, we are able to stimulate the cortex of the brain. And we have been the first to develop this technique in the United Kingdom. With transcranial magnetic stimulation, or TMS, you can perform a motor mapping. So you stimulate with a coil the cortex of the brain, and you can record peripherally the motor evoked potential. So you can elicit a contraction of the muscle, and you can record this on your running EMG. And the stimulation that we do is a navigated stimulation. So you have the MRI of the patient, and you can see in real time where you are stimulating, so that you come up with a map of the motor area in order then to avoid entering that area or damaging this area when you remove tumors that are close to motor areas. And the same things can be done for speech mapping. The speech mapping is done with the patient sitting on this kind of dentist chair. You can see the picture on the left. And the patients perform language tasks, such as an object naming or verb naming, while you stimulate the brain. And when they're unable to do so, either because they have a speech arrest or they have a phonological or semantic errors while they're doing the speech test, you can then identify again those areas that are important for language. So TMS is one tool that we have to try and identify motor and language areas before we take the patient to theater. And as you can understand, this is very important for us to then plan our surgical approach to tumors. Another tool that we have that has been developed in the last 20 years or so is tractography. You may have seen this as part of the clinical practice. Tractography is a way that we have in vivo to represent the white matter connections between different areas of the brain. It is a diffusion MRI technique that uses the property of water molecule diffusion. So if you have, if you imagine the water molecule inside the brain, they are not able to diffuse freely, but they usually diffuse around the white matter tracts, because these are like the channels that where the diffusivity can take place. And so we can use this property to being actually able to segment and identify the white matter connections. And why that is important? Because again, there is no value in sparing a cortical area of the brain if we then cut all the connections of that area, and this area become disconnected and unable to dialogue and participate in the networking of the brain that is so important for us to have a normal function. Just to give you an idea, imagine that you spare the motor cortex and then you cut the cortico-spinal tract. The patient will result with an hemiplegia that is usually even more severe than the motor deficit that you have if you damage the motor cortex. So again, sparing the white matter tracts is very important, and this is true with regard to the cortico-spinal tract and to the white matter tracts that subserve language function. And you may have studied in anatomy the arcuate fasciculus that connect the frontal and temporoparietal areas that are important for language, but you will study or you will know that there are other tracts that are important. For example, the IFOF, which is the inferior fronto-occipital fasciculus that connects again frontal area with the temporal and occipital areas, and the frontal slant tract, which has been more recently described, that connects frontal region of the supplementary motor area with the inferior frontal operculum, which is the so-called Broca area. So now you don't need to retain all these, the name of all this tract, but just be aware that clearly it is very important that as surgeons, we are able to spare the connections of the brain, because otherwise you will induce severe deficit by cutting these connections. One other weapon that we have, particularly useful for the high-grade glioma, is the so-called 5-ALA or 5-aminolevulinic acid. This is a porphyrin that cannot be metabolized in the glioma cells, so in the tumor cells of glioma and the glioblastoma. The interesting property of this molecule is that it becomes fluorescent when you apply a blue light that is in the blue spectrum over 400 nanometers. And basically what happens is that the patient takes orally the 5-ALA. It comes like a drink. They drink it on the morning of surgery. We take them on to theater. And when you switch and you change the filter of the light on your microscope, you can see that the tumor becomes of this red pinkish color. And that is helping you to differentiate between normal tissue that you clearly have to spare and the brain tumor that you want to remove. And you can see the difference, how suddenly everything much more clear becomes when you apply the filter and you use the 5-ALA to identify. You can see the difference in the pictures between the top and the bottom figure. And this is important for tumor identification, to see whether there is any residual tumor after we have removed the tumor. We think we have done the job, and then you switch the microscope again, and you can see that actually you're leaving a little bit of tumor behind, because we know that the surgeon eye is not always the best tool to identify residual tumor. And the use of 5-ALA has been demonstrated to be useful in improving the gross total resection. On the left, you can see the original randomized control trial that was done now more than 15 years ago. And on the right, data from our institution, from King's, with a recent reappraisal, again, in a real clinical scenario. And again, you know, the overall survival is better when we take out all the tumor, and 5-ALA can help us achieving that too. Finally, what I really love and what I really specialize in is the brain mapping. As we said, gliomas and brain tumors require us to understand the function of the brain, and you cannot operate on brain tumors without having this approach and this understanding. Brain mapping, as you can see from the picture, has not changed much from the good old days of Wilder Penfield, who was one of the pioneers of the technique. It started in the 30s, actually, in the 2030s of the last century, and he was a giant in the field, the one that really developed, and we have all followed in his footsteps. So again, I don't want here to go into the detail, but there are different ways that we have to interrogate the brain. And when we do motor mapping, we usually perform the motor mapping with these parameters, which is monopolar stimulation with the monophasic pulse. And we do the stimulation at cortical and subcortical level. And how we perform this, we do our tumor exposure. There on the left, you can see a tumor that is in the parietal lobe. So this is, you know the anatomy, the parietal lobe is separated by the central sulcus from the frontal lobe. The precentral gyrus is our primary motor cortex. The postcentral gyrus is our primary sensory area. And here what we have done is to map all the motor homunculus that was described by Penfield all that little numbers correspond to different muscle groups that were activated, stimulating the motor cortex. And we go from medial, number 1, there was the foot, the central bit 4, 7, and a little bit 5 and 8 was the hand and upper limb. And then as you go down laterally, you got number 12, that was the tongue and the mouth. So you remember the somatotopy of the motor responses from medial to lateral across the cortex. And the subcortical mapping then is to identify the cortico-spinal tract. Remember that, as we said, you don't want to cause a damage to the cortico-spinal tract. So here you can see the same picture at the end of the resection. We have removed all the tumor, and our margin of resection anteriorly was the fibers of the cortico-spinal tract. And there again, each little number corresponds to an area of the body where we had a motor response stimulating the white matter. So again, very important. Language is the other modality that we normally routinely investigate in patients with brain tumor. The setting is slightly different. It's done with a bipolar stimulation, with a 60 Hertz Penfield technique. And we usually performed a counting task with the speech to identify the speech arrest. So we ask the patient to count from 1 to 10, and they go 1, 2, 3, and then we stimulate. And when we find the area of speech arrest, which is usually in the inferior frontal gyrus or ventral premotor cortex, then the patient is unable to continue to count and they will stop. And for example, this is a case of a left temporal tumor. You know that the left hemisphere is dominant for language in the majority of patients. And the number 1 and 2 was speech arrest. And then you do other tasks such as object naming, action naming, verb or name generation to identify for anomias, semantic and phonological errors. And there you stimulate again with your bipolar to find out what areas are responsible for a speech, characteristic speech deficit. And then again, you do your resection. And as you can see at the bottom, in the bottom slide, the tumor has been removed, and you can see that little tag with the number 9 there at the subcortical level of resection. This is where we found language responses stimulating the white matter tracts that were linking, in this case, the frontal and the temporal lobe. So this was one of the segments of the arcuate fasciculus. Okay, so we have discussed a little bit about all the tools that we have, and I want you now quickly to bring through a clinical case scenario to see how we bring all of these into our real and everyday clinical practice. So we had a few years ago the referral of this 39-year-old gentleman who was an electric engineer. He presented with a partial motor seizure in his right upper limb, so that is already localizing the lesion in the left hemisphere. And then he was complaining over the last weeks preceding the seizure that he noticed some clumsiness in his hand. And this was quite important for him, because working as an engineer, you can imagine that he needed his hands to do fine motor tasks. He got the MRI, and as you can see, this tumor is localized in the primary motor area, and it has the characteristic that we described for so-called low-grade glioma. It is hyperintense in the T2 sequence, and it doesn't take contrast in the T1 after gadolinium. So it looks like a low-grade glioma in a patient that is otherwise fit and well. And I remember that there was a discussion in our MDT, that's the multidisciplinary team, where we meet with oncologists, radiologists, several neurosurgeons, and we discuss the cases that we select for surgery. And there was a real uncertainty about this patient, because we said, well, the tumor is in the primary motor cortex. if we operate, there is a good chance that we'll end up being hemiplegic and lose the function in his right, it was his dominant side, and that would be a disaster for him. So we decided to investigate a little bit and apply some of the tools that we described. So we did the tractography, and with tractography, we saw that the tumor, rather than invading the cortico-spinal tract, was displacing the fibers of the cortico-spinal tract, as you can see on the picture on the left. So the tumor was growing at the level of the cortex, but it looked on tractography that the connection and the fibers were still there. And then we did the TMS, and as you can see from the color-coded responses are how strong the motor responses are. And you can see that, again, the two major responses for the upper limb and lower limb seem to be displaced laterally compared to the tumor. And so we said, well, maybe we can remove all or part of this tumor. And what we did was to do an awake craniotomy, so to wake the patient up to do a fine motor task, intraoperatively, finger tapping. We did the image on the left of the screen, a cortical mapping. And again, you can see that we identified the motor responses and the sensory responses. So 1, 2, 3 is the motor hand. 4 and 5 is the motor lower limb, foot. 6, 7, and 8 is the sensory hand, so tingling and pins and needles that he was reporting in his right hand and right fingers. And 9 and 10 was the sensory foot, again, pins and needles when you stimulated that region in his leg and foot. So we knew that we had to spare this region, but look, the tumor you can see, even not being a trained neurosurgeons, you can make out that the tumor is that lump in the center of the picture and in the center of the exposure. The tumor did not elicit any motor response. So we knew that we could try and remove as much as possible. And then at subcortical level, we found the stimulation of the cortico-spinal tract as well. And as you can see, the fibers there were again displaced rather than invaded. And this resulted in a complete macroscopic resection, and the patient did well. He was weak, he developed a degree of weakness immediately after the surgery due to the swelling, but he then recovered and he was able to continue to work as an electrician. So again, the other key message is that you need to have this view of how to approach tumor, combining preoperative and intraoperative strategy, and ultimately taking time also to sit down with the patient to see what are their expectations, what are their goals in life, and what is important to them. Is the patient a teacher? Do they need high mathematical skills? There are areas of the brain that you can investigate for that. Is the patient a violin player? And well, if your patient plays the violin, then you can wake them up and having them playing the violin, while, as you can see, you're resecting the tumor and you have your neurophysiology running in the background, so you are sure that you're not causing any motor deficit. And this was my final message to you. This is the team, is clearly a team effort with all our neuro-oncology, and I thank all of you for your attention. If you are really interested in the topic of monitoring brain mapping, we run every year a course, which is usually in November. We haven't fixed the date, but take a snapshot of this slide and be in touch if you want to participate. Thank you very much, and I'm happy to take questions if there is any.
So I actually had a couple of questions which I submitted onto the chat. I think the first one was answered. So my question was, what's the most common type of glioma that
That's right, yes.
Come across?
So the most common type of glioma is it's called glioblastoma. And this is unfortunately also the most aggressive and the one with the poorest prognosis. Even with the complete resection, as I said, the survival is in most cases limited to 2 years, with the majority of patients surviving anything between 1 and 2 years. And then you have a tail in the survival of a few patients that do well considering the diagnosis of glioblastoma and live more than 2 up to 5 years, and some patients that do really poorly and they live less than 1 year. So that's the glioblastoma. How we come across on a day-to-day basis? Well, through the clinical presentation that we said. The vast majority of patients are referred through an acute setting. They are unwell and they get screened in A&E, usually at the local hospital, because they have a neurological deficit or raised intracranial pressure and they become unwell, or a seizure. And so they get a scan. Usually scan is the first investigation that is done in an A&E setting, accident and emergency department, and then they're referred to us. So for cortical mapping and defining the motor strips, is the numbering the same for every single brain or can it vary? Not sure what they mean here by the numbering. Is it the little number that we put?
Yeah, the numbers that you put in to define like the percentage.
No, it's actually very random. No, that varies. We don't, so we always put down our number and then we say, okay, number 1 is the arm, number 2 is the foot, number 3 is this or that. There is no logic behind it. And there is no, it's not codified. Okay. It also depends a lot on what part of the brain you expose and how much of the motor cortex. So, you know, the responses that you obtain are also different.
Okay. I'm so sorry. I have another question.
Yeah, please.
Sorry. So let's say when you remove the tumor, one thing that I remember from last year when I was doing pathology, although it seems like many moons ago, sometimes you can have the complication of edema, especially cerebral edema, because it would have generated around the tumor. How bad is that particular complication? Does it depend on the size of the tumor, or would it just, is it something that inherently it's just bad and we try and manage it during the operation that it is reduced as much as possible?
No, absolutely. No, you are absolutely spot on. So the edema is one of the major problems that we face whenever we are surgical approach tumor. And the edema is usually related to the malignancy of the tumor. So more malignant tumor usually exert more edema because of that process that I mentioned, the disruption of the blood-brain barrier. You studied probably in anatomy that between the blood, the vessel, and the brain, there is a barrier with tight gap junctions. Whenever there is a malignant tumor, this blood-brain barrier can be disrupted, and that would result in edema. Yeah? There are a number of things that we can do to counteract the edema. One and the best is steroids. So you give high-dose steroids to these patients, and we usually give dexamethasone, which is a very potent steroid, because the steroids are anti-edema medication, and the swelling can improve significantly. When you have one of these tumors, for example, you start the edema even a few days before the surgery, because you want the brain to be nice and relaxed at the time of surgery and not swelling up as you do the surgery, because that could be very dangerous. The other thing that you can do intraoperatively, usually, or perioperatively, so shortly before and after, is to give antiosmotic medication, like, for example, mannitol or hypertonic saline. And we use these a lot in theater.
Okay, right. Does anyone else have any questions? Thank you for my answer.
Yes. I have a question about use of gamma knife in neuro-oncology. How often do you use it?
So yes, so gamma knife is a way of giving a stereotactic radiosurgery. And this is, let's say, a special form of radiotherapy that has the advantage of giving a high dose of radiation to a very focal target, again, sparing the surrounding brain. The use of gamma knife or other ways like LINAC but let's say in general, the use of a stereotactic radiosurgery is mostly for brain metastases that respond well to SRS. And our current NICE, the National Institute for Clinical Excellence, these are the UK guidelines. If a metastasis is less than 3 centimeters, you can decide on, depending on patient factor and other things, whether to operate or give gamma knife. And it's usually more useful in the setting of multiple metastases that are clearly more difficult to address surgically. So when you have more than one metastasis, you can target the different metastases with SRS. The other tumor that responds well to TMS is meningioma. I haven't mentioned meningiomas because these are extra-axial tumor. So we may arrange a lecture in the future specifically for meningiomas, but meningiomas respond very well, and vestibular schwannomas. It is not currently very well investigated, but it is limited, the usefulness of stereotactic radiosurgery in the setting of glioma, because glioma tend to be quite diffuse tumors that don't have a very good border and differentiation. They tend to invade and spread into the brain. And therefore, you need a more conventional radiotherapy where you can cover a more extensive area.
Okay, thank you.
Thank you.
Actually, I have one more question. So far, when I was watching neurosurgery, where there was a tumor excision, there was always an involvement of microsurgery. Is it always the case?
So most of us, I would say, yeah. I mean, most of us would use the microscope to remove these tumors. And I routinely do. I mean, all the pictures that you see were taken, most of them, let's say, were taken with a microscope. Some just for the purpose of illustration were taken with a camera. But yeah, I would agree on that. I mean, I use the microscope virtually for every brain tumor case that I do.
All right, thank you.
Does anyone else have any other questions? Okay, right, I'm going to take that as a no. Right, thank you very much all for attending. Before you go, I'm just going to fill out, I'm going to send this feedback form in. Now I'm just going to stop recording as well, sorry.